Thank you very much, Madam Chairperson. I really appreciate your kind words, and I must thank Professor Wase for his really wonderful organization of this conference. Congrats to all of you. It's been very well organized with fantastic lectures. I enjoyed the ones given by the preceding speakers. I only hope I can do as well as them. I will just share my screen right now, and hope you can see my slides. Hope my slides have appeared in front of you. Very good. So once again, thank you very, very much for inviting me to be part of this conference. Also, as the CME chair for the Asia Pacific Stroke Organization, I again thank you for involving us in this. And we were proud to endorse this meeting. And we can clearly see why, with the high academic content, we made the right decision. Congrats, Dr. Wase. Congrats to the society. The next few minutes, I'll cover some guidelines that have been published on how we can manage better patients with stroke. Here's the roadmap. I took all these pictures from the Pakistan tourism website with beautiful pictures, and hope to cover these in the course of the next few minutes. After some intro remarks, the journey the patients take from the pre-hospital, hospital, through imaging, to neurocritical care, rehab, and outpatient, before making some concluding remarks. As you've heard, stroke is a major cause of death and disability globally, in Asia and South Asia especially. There are many guidelines published on how to manage stroke. The American Heart Association, the Human Stroke Organization, all have published how to manage stroke. But despite that, stroke care is a challenge, and I find it's a very wonderful paper written by Dr. Farouk in a collaboration with us on the challenges of stroke care in Pakistan. And having COVID has challenged everybody. Every healthcare system is much struggling with this, from delayed arrival to hospital to slowing of things in the hospital, and the concern of spreading COVID within the system of care when patients move from place to place and may pass the virus to healthcare professionals. We've heard already from the very excellent speakers just now on how COVID and COVID vaccination can cause stroke, be it ischemic, hemorrhagic, or venous. Sadly, there aren't enough clinical trials to provide us evidence to what to do for COVID stroke patients. So we think the best thing is to do what you normally do, but in a very careful way. The guidelines published so far on stroke care are here for your reference. I'd like to share with you now the latest guidelines. And Professor Wase is a very important member of this team. He was a part of this group that put this together. I'm glad to share this with you, published just this year in March. So let's talk about the pre-hospital. Patients are trying to get to hospital by whatever means they best can. What can we do in this setting? Well, the guidelines suggest that all patients who are picked up should be treated as potential COVID cases. This is to protect the healthcare system and the healthcare ambulance workers in case they pick up the virus. So please be careful until there's a screened negative in all these patients picked up by the ambulance. And therefore, each ambulance team member should be adequately dressed in gloves, caps, masks, PPE, shoe covers to protect themselves. Because when facing a high-risk COVID patient, they may get the infection from them. In those who are known to have COVID, these patients are probably best on face masks, respirators, to protect the staff. And all staff should be trained on how to wear the equipment, how to put it on, how to take it off, and how to dispose of those devices and the protective equipment. In addition to talking to the patient about the symptoms, when the stroke happened, how ill are they, the risk factors, the emergency services must ask about the red flags for COVID-19. Do the patients have fever, having cough, do they contact anyone with COVID-19? So if they have any of these features, that they may be at risk of having COVID and should be red flags to be passed on to the receiving hospital. What the ambulance can do is to inform the hospital in advance, I have a stroke patient, I have a patient with stroke who is a high risk or suspect for COVID. By doing so, the hospital can be prepared with all the requirements to protect the staff and to therefore treat the patient best they can. Where probable, patients should wear a face mask where they can take it, and after each patient, the ambulance should be cleaned thoroughly in case there is a COVID virus sitting in the ambulance. We do not know if having ambulances only for COVID suspect patients, only for COVID patients is possible. Because we are so short of ambulances, I think it's impractical. If it's possible, that's very nice, but it's an impractical thing to do. So I think the best thing is to have ambulances take care, move patients, and clean the ambulance fast as you can. There's some talk about this, and this happened in Singapore too, where those are COVID sent to just one center in Singapore. But we could do that. But very few countries have the flexibility or the ability to do this safely. But this is done. It's very, very good if it's possible. So here's an algorithm we published that those that stroke symptoms were high risk with COVID are probably best sent to a single center where possible. It's usually not. Otherwise, wherever they come, if they are COVID suspect, if they have just symptoms, they all should be screened for COVID at a rural hospital. And this can be by ARTs, which are now widely available and not terribly expensive. Once a diagnosis is made, one decides COVID positive, at risk, or negative. If there are positive at risk, then therefore, within the time window, proceed with the care. If they are not in the time window, delay the treatment. And what does is, by having a distinction of line, you separate the infected and non-infected to save the healthcare system and to protect the staff and the equipment. By doing so, we can do our best to provide the best level of care immediately. But as mentioned by the chairperson, this may allow us a delay because screening the patient, protecting them, dressing them will cause delays. But still, if we have a protected code, if all things move smoothly, the delay is not very long. What happens in the emergency room based on this algorithm? Well, the ED should be informed in advance that a patient is coming and therefore they're fully prepared. Once the patient arrives, even they walk in, they should also be screened by questionnaire and by a test like an ART test. If positive or suspect, they must go through a separate channel, a protected pathway to protect the patient, the public, and healthcare workers. The patient may wear a mask, but the worker should be fully protected in PPE. It's recommended that those who are suspect or have COVID should be managed in a separate area, totally screened off, and moved through separate corridors where possible. Otherwise, things should be proceeding as usual. But some suggestions: minimize the staff in contact with the patients, use telestroke where possible, and importantly, minimize aerosol procedures because this may send the virus into the air. If negative pressure rooms are possible, please use them. So the philosophy is infection control and prevention, and do not delay. By having a well-oiled pathway, things can move fairly well. Having done the initial phases in terms of getting the ambulance to be careful, the ED to be careful, we then go on to imaging to see what we can do for the patient. Imaging is such an important part of stroke care. We want to make up a stroke mimic and to pick up strokes that are hemorrhagic and ischemic and to tell them apart, even venous thrombosis. So imaging is key for our patients. How can we do this safely? Where possible, a separate machine, a separate area. Not always possible, but if it can be done, that'll be very good. Then patients in mask, healthcare workers all dressed up. If it's not urgent, the patient can be done at the end of the day, and then the machine and the room totally cleaned. If possible, defer ultrasonography. Some would say when they come for MRI or CT, do the CTA or MRI at the same time to avoid subsequent ultrasound exposure. The suggestion is that because X-rays aren't always the best way to pick up COVID virus infection in the lungs, perhaps a rapid low-resolution CT can be done while the CT brain is being conducted. At all times, minimize the staff in contact with the patient, all in PPE, minimize in the room, and clean the room after the patient. So the philosophy remains infection control and no delay, have a clean, protected pathway for such suspected patients. Having done imaging, you want to open up the pathway for these patients, unblock their arteries. What can we do in this setting? The guidelines say there is no need to prevent these from patients from getting thrombolysis or thrombectomy. Things should go on as before. The only caution is if you have to intubate the patient, use it preferably in a negative pressure area. Maybe all those who are in the time window for thrombectomy to be intubated in the ED already, so things are moving smoothly and there's no struggling later on in the imaging room to do this. Again, minimize the staff that are there, all protected, minimize equipment, and clean the room. And the philosophy remains infection control, protect the patient, protect the public, protect the staff. then we can move smoothly and not have the system have to be locked down because of COVID infestation in the hospital. Having gone through the acute procedures, we then have some patients who go to ICU and some in the stroke unit or in the ward. What can we do for these patients? Again, no randomized controlled trials to prove this, but the system should be such that we should therefore provide critical care for those who may benefit. Do not deny them this care, but remain in the cognizant fact that infection control and PPE is crucial for the patients and for the staff. Again, aerosol generation should be reduced as far as possible. If done, use negative pressure rooms. If you want to intubate the patient, video guided is preferred over direct laryngoscopy, again, for the safety of patients. We can wear the mask and gloves, but may still breathe accidentally if there's a leak in the mask, and therefore it's safer to use something video guided. Otherwise, care is continued as per normal. If they don't need ICU care and go to the ward, what do we do? Those are COVID suspect, COVID patients, or the acute stroke or non-COVID, the principles are pretty similar because the whole hospital is careful of moving patients anywhere. We don't want to have patients moving around who have no COVID who then pick up COVID accidentally. So they all wear masks, staff are all adequately protected, everything done on the bedside in the COVID or non-COVID patients, neurosonology on the bedside for sure, and for other patients, maybe move is needed. For a patient at a CTA, MRA, there's no need for neurosonology. Echo at the bedside, Holter at the bedside, X-rays at the bedside, and any other imaging required, second MRI, second CT, unless emergent, please do end of the day in a dedicated scanner where possible. Need rehab, again on the bedside. So by doing this, having a clear separation, we hope to keep the COVID patients safe and the healthcare system safe from further issues. We know rehab is a very important part of stroke care. We know from the data that thrombolysis, stroke imaging, stroke unit care is all important, and all our patients with COVID deserve the same level of care. We also deserve rehab. We suggest that at least 45 minutes a day of rehab, 5 times a week for those who can participate, again, to achieve their functional goals. But do monitor carefully for these patients. Many of them feel lonely, they feel rejected, they feel agitated, they can't sleep, they're depressed, some become aggressive and even suicidal. So watch out for these, often forgotten when we rush around looking at all other many patients. COVID, some patients maybe can't wear masks, they can't maintain a distance, they feel lonely and depressed, and they may therefore come too close to healthcare workers. So please be mindful of this, but please support them best we can emotionally as well as physically. Tele-rehab may have a special part to play in this setting, and therefore this is possible. It's a way to rehab our patients in the inpatient setting. Family wants to visit. I know it's very difficult. In most hospitals, visitation is cut to zero. Having video calls to families, allowing phone calls is one way of lifting the spirit of our COVID patients and non-COVID as well. By doing all this, infection control is maintained and staff are protected and patient as well. So we give the best level of care we can, including giving them good rehab as far as possible. After discharge, patients go home. They come to see you for care. What can we do in this setting? What do we recommend? Well, likely by the time they come to us, they're already negative or had treatment for COVID already. But whatever happens, we should still continue to be cautious. Please do the COVID screening by doing the ART testing. But we do know those that COVID before may test as positive for the virus, but not carry active virus. So be aware that those are COVID positive on ART testing, the COVID before may not be actively infected with the virus. So bear this in mind. But continue all the therapies, all the antithrombotics, anticoagulants, blood pressure reducing medications, statins, rehab should all be continued. But perhaps reduce their clinic visits. Don't have them to come back too soon, as we otherwise would like them to come. Avoid, by doing so, use teleconsultation where possible, video calls on handphones are possible, or even a phone call. I know we can't do a proper neuro exam by phone, but if patients are well, I think a teleconsult will do a good enough job. Outpatient rehab is important, and rehab should be done where possible. In Singapore, we try our best to deliver the medicine to the patient's home, provide them or family coming. By having a home delivery service free of charge, it gives the patient comfort that medicine arrives to them in time. Even more important now is to train the family and caregivers to look after the patient well, to support them physically and emotionally as best they can, and to contact the medical staff as soon as any concern occurs so the chain of care is continued from the inpatient set, from the pre-ambulance, pre-hospital service, emergency, inpatient, outpatient setting, so they all feel very well cared for. The patient in the middle, their family around, the healthcare service surrounding them, no matter whether it's COVID or not. And so, Madam Chairperson and gentlemen, some concluding remarks. We know COVID has played a tremendous stress on healthcare services. Patients come late, they don't dare to come, and some, when they come, are very, very sick. We now have new models of care with the Protect Stroke Code to keep the patient safe and to isolate them from the others. We have specialized places for screening the patient in emergency, maybe stroke ambulances, places where we have special scans for these patients, and special wards where the patients can be managed. So all these are trying to provide better care for our patients, while again looking after the fact that they are very infectious. The usual treatments should be continued no matter what to everybody. We'll still know what the best is, but just be aware that infection is a concern. And therefore, be aware also that because aerosolized procedures can pass infection to others, be aware of what we do, intubation. Until we know better, we use the best evidence, look for new publications, new clinical trials for our patients. I think it's important we continue our stroke pathways, our stroke unit care, coordinate from the time they hit the ambulance all the way through hospital and after discharge. Don't forget them, they're still our patients. At all times, infection control. By doing so, I think we can provide the best level of care to all our patients, despite the very difficult setting that we are facing, trying to manage COVID and stroke in the healthcare system. Thank you very much.
Okay, thank you so much, Dr. Ramani. That was a very, very insightful and detailed presentation on various aspects of stroke care. And I think that would be a very valuable paper for many of us to sort of go back to for guidance, because we are still very much in the middle of the pandemic. It's not over yet. So thank you for being a part of this session. I'd like to invite Dr. Ehsan Noman now for some of his comments regarding the COVID and stroke, and also regarding this entire session. So please, Dr. Ehsan Noman, if I could have some comments from you.
Thank you very much, Dr. Mari. I think this is the most wise session for me. I have become so wiser about the COVID and its related neurological complications. All the speakers are so excellent. I have no words to say. And I just want to highlight the few more things. You are absolutely right. We are just in the middle of the pandemic and we have to face such a more waves. So I think this is the right time to we work as a team to collect more data from our own country so we can make our own guidelines to give the maximum benefit to our community and country. And I think this is my comment for the, thank you very much for this beautiful session. Thank you.
Okay, thank you very much for your comments and appreciation. I'd like now to, for Dr. Vase, if he could come on stage and give the shields to the speakers that are present. Thank you all for being with us for this session. I'm sure it was a learning experience for all of us. So thank you.